Hey everybody, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Georg Supp, and he's going to talk about the research he published last year called "Do Patients with Low Back Pain Remember Physiotherapist's Advice?" He's also going to talk about directional preference exercise and the overuse of the term mechanical. Georg has been a PT since 1992, and he received his diploma in MDT in 1999. Georg is an international instructor for the McKenzie Institute International, and he is the vice president of the German McKenzie branch. I hope you enjoyed the show. Hi, Georg. Welcome to PT Pro Talk. How are you today?
I'm fine, thank you. Great weather here in Germany. It feels like spring currently.
Awesome. Thank you so much for participating here with us today, for taking the time. And let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Yeah, so I graduated in 1992 at PT school in Germany, so that's quite a while ago. And then I worked in different rehabilitation hospitals and private clinics. And in 1997, I launched my own clinic together with a good friend. We are still friends and colleagues now. So now I'm the owner since 24 years already. And then it's a typical story. I was frustrated after about 2 years of my working as a PT in the early 90s. And then somehow by coincidence, I jumped into a McKenzie course and it changed everything. And then it's maybe the same story as with many other colleagues you interviewed before. So I did my diploma in Minnesota in 1999 and started teaching McKenzie in Germany, Switzerland and Austria about 2001, and since 2016 I'm also an international faculty teaching in different parts of the world. Yeah.
Awesome. So it's a lot of experience teaching the method as well, right?
Yeah, more than 20 years now.
Yeah, good. And I know that you also like a lot of research, right? That you study a lot and publish a lot of articles, papers. Right.
Yeah, most of it actually it's really low level articles. I now have some peer-reviewed letters and the expert study as a co-author and our research we published last year on communication. But the rest is mostly invited articles, comments. So scientifically very low level. it's more actually really to target the clinician. And I didn't add too much to the scientific world yet.
Oh, you are being so humble. All of these studies that you do, I'm sure that add a lot of value for our area, especially the McKenzie world. So I remember, I think it was last year, the webinar that you were talking about a study that you were doing about what was the topic. I just remember the pictures, you were progressing.
Yeah, we did this return to activity algorithm. We were working on this, and we are still working on it. Actually, it's still work in progress. So
nice.
we tried to come up with an algorithm for return to activity for low back pain patients, which is still we are still working on it, and we are still field testing in the clinics, and it's still a lot of work to do, but it's fun. Yeah.
Yeah, I'm glad that we have people that enjoy doing that, because that's very important for our profession. So thank you so much for doing this for all of us.
Yeah.
So let's talk about the study that you published last year that's called "Do Patients with Low Back Pain Remember Physiotherapist's Advice?" So could you just tell us a little bit about that?
Yeah, it's my pleasure. Yeah, we actually, having a lot of clinical experience in the clinic, so with my colleagues and all over the years, so we found that quite regularly we experience that patients come back and you got the idea that they just don't know what you were talking last time about. So maybe let's say they show you the wrong exercises, they give you a strange explanation of whatever, or maybe you see a patient of a colleague. A colleague treated a patient last week maybe, and this week the patient ends up with you, and maybe your colleague gave you some information on this patient and how he behaves or she behaves and what was the exercise. And then you are kind of surprised that the patient tells you another story. So we asked ourselves, do patients really hear what we say? And then we checked the literature about that. So to find out, is there any literature, is there any research on this specific topic? So day one in the clinical setting, in the private practice, how good do patients actually remember or really hear what you say? And we didn't come up with results. We found some research on communication and some on adherence, therapeutic adherence, compliance, all this stuff, but nothing really on this very basic, very starting topic. So what starts on day one. So we didn't find that much on this. So we decided to run a research project on that.
And so tell us a little bit, what are the clinical implications of your findings and how this related to MDT?
Yeah. So first of all, so we asked the question, do patients remember what therapists tell them? And we found surprisingly yes, because we had 90 patients in this, it was a mixed method study, so qualitative and quantitative research. So we had 90 patients in this study and so 90 questionnaires and 26 physical therapists working on this. So at the end, we found that the patients we had in the study, they remembered quite well what the therapist told them or gave them, therapeutic advice, information, exercises. So, and we were really wondering how could this be the case, because we expected something different. So our hypothesis was that it might come up with some very mixed results. So we found that they understood what we told them, and so we tried to find out why does communication work in this setting. It was mainly our clinic, but also a hospital in Zurich in Switzerland and 3 other outpatient clinics in Freiburg. But most of the patients say they were treated or evaluated in our clinic. So what we found is patients understand what we tell them or hear what we tell them if we check for 4 different things, or if we are aware of 4 different aspects. So first of all, there should be shared decision making in the therapeutic process already. So in the diagnostic process. So usually shared decision making plays an important role when it comes to therapy. So together with the patient, we might decide which medication to take, or maybe how many times he can do the exercise during the day or whatever. But in our study, we found that the patients, they really appreciated to be involved in the diagnostic process. So that was number 1, shared decision making. And number 2 was the exercises. The exercises should be simple, and there should be only a few exercises. So we found that if you are using more than 2 exercises or 2 information, the risk that the patient does not remember what you tell them, or him or her, is very high. So maybe only 1 or 2 exercises, shared decision making. And then we found that it's very important to ask for expectations, which is not new. We know that from the literature, and that we should approach worries about back pain. So that was, and nevertheless also it should be an active evaluation. So the patients, we did interviews with 14 patients, and the patients really appreciated to have an active evaluation. So make them move, and so, yeah.
And what is interesting, that McKenzie has all of these components on the education process. So I was just
Absolutely.
wondering that probably the same study wouldn't have the same results with other techniques that don't use the same way of approaching that, because usually we give 1 or 2 exercises, but traditional physical therapy, sometimes the patients, they leave the clinic overwhelmed with a list of exercises, which makes harder for them to comply with the exercises. And also McKenzie is very active, opposed to passive. So I just think it's so interesting, these results, that is a little surprising that they really understand and remember all the instructions. But also, I think the educational component of the method is super strong. So I'm not actually surprised with the result. So I think that's, and actually incredible.
True. Yeah. It's kind of underrated. So these aspects in the McKenzie system are underrated. So very often we insist on the repeated movements and the mechanical aspects and all this stuff, but these soft skill issues, they are very often underrated. And as you said, the McKenzie system offers all this. So it was not meant to be a McKenzie study, not at all. The only aspect where we actually mention McKenzie is in the limitations of the study, because we described it as a limitation of the study because 86% of the patients were evaluated by McKenzie trained clinicians. So we have to see, if you repeat this study in another setting with other clinicians, how might be the result. So, but this is only an assumption.
Yeah.
But I agree, it is the system who helps to make patients understand what we tell them.
Yeah, I'm just curious if someone would try to do the same study in other settings and other setups with other kind of specialties, just to see what the results would be.
Sure. Yeah, and interestingly, we were facing a lot of bias, also bias from the reviewers, for example, because, for example, one reviewer was criticizing the fact that, McKenzie, these seems to be all McKenzie stuff, and McKenzie is so simple, they only show extension and lying, and it's easy to remember that. So that is a criticism. But actually, in our study, 47% of the patients, they had a directional preference. So we had about half of the patients were derangements. So, but the other half also, they had some improvements. So it also worked with the non-derangement patients, which is great.
Yeah. Well, we would expect that probably would be harder to have the compliance because the results are not so quick and so easy to measure. And so that would probably...
Maybe it is actually more the way of the evaluation is done, more the interactive and the shared decision aspect of the evaluation than the final exercise, which makes people understand what they should do or remember what they should do.
Yeah, and our way of thinking in the McKenzie method, I think it's interesting because we do all of those things, and sometimes we don't even realize that we are doing this way that is so systematic that I think it really helps to improve the outcomes and the patient compliance. We briefly talked about that on the last episode that I had here with Cara. So we were talking exactly about education and how we can have better results. So I think that's a very important part of the method.
Sure, yeah.
So now let's change a little bit the topic and let's talk about directional preference. So why do these exercise work?
Yeah, that's an interesting question actually, and I think at the current status, at the current time, we only have assumptions why it works. So we don't know. I think we don't know why directional preference exercises work. So, and I'm not the one who thinks that it's really the mechanical aspects of these exercises. I'm not sure about that. So, and up to date, we don't have convincing evidence on this, and we don't have studies who really looked at why are these exercises helpful. So, and if you ask patients, and I started some years ago actually asking my patients, why do you think, why do these exercises help? And that is really interesting. And I plan to run a research project on this. Just ask my patients, why do they think, do the exercises help? Not only directional preference exercise, but also. And a funny answer I received, I think some weeks ago from a patient was, he was kind of surprised why I'm asking these questions. And he said, it just because I'm doing them. It's easy, I do them. That's why they help. So, and similar answers I get from other patients. So they tell me very often, it's so easy to do them. I can include them in my daily life, or I understand why I do them. So very rarely they give me a structural explanation, because I don't give a structural explanation, but I ask my patients, so what do you think, does this help? Some patients come up with, oh, maybe it's just better blood flow in my back or in my knee or whatever, or the metabolism is better, or maybe I pushed a little bit in this direction. Or some just tell me, oh, I've felt so stiff, now my joints, they feel just more move fully and freely. So it's really interesting. So why are directional preference exercises helpful? Why do they work?
Good
I
question.
know that historically we thought that some stuff in the joint, in the back, in the knee or wherever is moving backwards and forwards. But we now know from the evidence that this might not be the case. And for sure, not the same stuff is moving in the knee than in your back or in your neck. So I think the explanation, just to limit it to the mechanical aspect or structural aspect, that is way too easy, and I think you don't exhaust the full potential of the method and also of the exercises.
So since you mentioned the mechanical part, so why should we avoid the overuse of the word mechanical?
Yeah, a funny coincidence. Last week I heard from I got the quote from a friend. He heard from a clinician an answer on this, and the clinician said, because our patients are not cars. And I think there's a lot of truth in this funny and straightforward statement. So, and to be honest, I think I haven't run a single mechanical evaluation in the last 15 years. And if somebody would call me a mechanical therapist, it would be almost insulting, because I think we don't do mechanical therapy. Our patients are not machines, are not cars, are not bikes or whatever. So we are always treating the person. And maybe it's also a cultural or language issue. In Germany, if you tell the patient we are doing a mechanical exam and then we do a mechanical treatment, that sounds a bit strange. So I know where we're coming from, and it was fantastic in the 50s, 60s, 70s, and 80s when Mac came up with the system. It was so important to set a counterpoint against surgery, against medication. So to show that movement and exercises can be so valuable. So, and he started this mechanical thinking or talking about mechanical aspects, which was fantastic at the time. But I think we moved forward, and we should not limit ourselves to just be the mechanical therapist. I don't want to be a mechanical therapist, not at all.
That's very interesting, because I think, at least in the US, in Brazil, we use a lot this term related to McKenzie.
Might be a cultural or also a language issue.
Yeah.
It can be so, but I don't feel well using this term, and up to now we don't really know what is mechanical pain, and we don't have mechanical syndromes. We have the McKenzie syndromes, and different diagnoses. I think we tend to overuse the mechanical in our system, which kind of we limit ourselves, we restrict ourselves to only this mechanical aspect.
So let me ask you then, how would you describe to your patients and to the public in general, what do you do? So how do you test? How do you use the systems? Like, do you use other words to describe?
Yeah, I'll talk a lot about movement, activity, exercises. So, and nowadays people are well aware that they don't move enough, they don't exercise enough. Very often they have kind of awkward postures during the day, which we know might be responsible or not for some pain. We don't know exactly. There's a lot of discussion on this, but it's quite easy to get them on board if you talk about movement and metabolism and just getting your muscles functioning and blood flow and all the stuff. So it's not mechanical. It is everything. So we know that when I talk with patients about loading strategies, I explain them how fast their musculoskeletal system might react, or their system in total. So and they all agree, the fastest change you have is up here. So if you feel better, if you start, for example, exercising, or you start a workout, you feel better. Immediately after you stopped, you feel better, or you have done something. So you feel better here up in your brain, or in your mood is better. And then cardiovascular is also reacting quite well. The muscles are reacting, the tendons a little bit slower, the joints slower, the bone very slow. So I explain them how the system reacts on exercises. But they are all well aware that the first thing which might react is their mood. They feel better. We should not only focus on what we think, what is happening with our exercises specifically, we should also think about the positive side effects this all has. So, and I think there was a nice podcast, or was it I don't know, was it an article? I read something about, I think it was from Craig Lehman from Canada, about the positive side effects of exercises. So even if we can't show that, for example, exercises for your knee are beneficial for your anterior knee pain, but the exercises, they might make you move more than usual. So you might burn calories, you might lose weight, you might go out and have some fresh air. So with all the positive side effects. And maybe it's the side effects of direction preference exercises which are so beneficial. I don't know, and I don't care. So
it's a whole new reflection. I appreciate a new insights and different ways of thinking that make us really stop to think about it, because I haven't heard McKenzie from this perspective. So it's my first time, and I think probably a lot of people will also have the same impression. Yeah. So I think it's just a valid point to think about.
Yeah, I don't have the answers. I just asking the questions. I'm just, if I can, I think we could discuss it, or we could think about it at least, and we should not stand still and just say, okay, it has worked for the last 60 years because anatomy didn't change, so it still has to work, and it still works. No doubt about that. But I think it's worth to give it some thought. So
yeah, absolutely.
Have a broader perspective on this, on pain and on our patients. Even when we are running McKenzie exams, they are not purely mechanical, and they have never been. McKenzie has always been interested in the psychosocial aspects. Unfortunately, we didn't publish on this until last year, when we had the first systematic review on McKenzie and psychosocial aspects. So we didn't have it in the manuals. We have it now. We didn't have it in any articles, so we have it now. But in the first 30 years of McKenzie, it was not really out in the public that we are not focusing only on structures, on body structures.
Yeah.
So,
Well, thank
yeah,
you
it
so
doesn't
much
sound
for
like
all these
McKenzie,
new
I know.
insights.
Yeah, sorry, it doesn't sound like McKenzie, but it is. So I think it is.
Yeah, no, I appreciate all these insights and all the reflections that hopefully a lot of therapists are going to stop to think a little bit more about it, and
Yeah, and
who knows?
it's not an official viewpoint. So I'm a member of the Education Council, but this is not Education Council stuff. It's just my perspective. So
And
it's just
yeah, and McKenzie involves a lot of different components as well, as we know.
absolutely.
And it's something to consider for sure.
Yeah, true.
So let's transition to our final questions. What are the resources of information that you like, that you would like to share with us?
Yeah, I really like to, so as source of information, I really like to network with other people, with colleagues all over the world. That is, for me, that's the greatest inspiration. I don't know if this is really information, but it's inspiration. And when it comes to information, I think Twitter is a great resource. If you are able at some point to just close the computer or don't check your smartphone anymore, because otherwise it drives you crazy. Because on Twitter, it feels like every 5 seconds a new article is somehow promoted, and also there is really a great group from Germany, Physio Meets Science, and they are very active, and they started with some stuff in German, but they're really active also in English, and they are producing a lot of good stuff. They are just searching for research day and night, and they just promote it, and they post links to articles, and that's a great group, fantastic group. So they provide a lot of insight. Well done. So I can really recommend them. Physio Meets Science. You find them on Instagram, Facebook, Twitter. They're really active. Great group. So it's just to get information. But I have to admit, I think it's more about inspiration and how you analyze the research. So because very often it has two sides of the coin. So not every great article is as great as it seems if you look behind the curtain. So, but it's great to have all these articles, but you also have to be careful with it. Yeah.
Yeah. Well, thank you for all the suggestions. And I've noticed more and more that a lot of PTs and great names of our area are on Twitter. So I have to start my Twitter. I don't have, so it looks like I'm missing stuff there.
Yeah. Yeah. It's a bit, there's some ambivalence, because can really be stressful if you are aware of what is published and what people do, and it really makes you feel sick and inferior. But yeah, if you can handle that, I think that's a great resource. Yeah.
You have to know how to handle that. Otherwise, you're going to go crazy.
Sure.
And what advice would you give to clinicians that are starting their careers?
Yeah, I've heard these questions many times. So I think the very important is to be humble and listen to your patients, which is not a new advice, but it is actually really a valuable advice. Listen to the patients, and as soon as possible, get an idea what is the expectation of your patient, and get an idea what your patient thinks about his situation or her situation. So I have two questions for patients which I always ask. One I ask always, the other one very often. One is, of course, so what are your goals and your expectations today, which is quite common. And then if it's getting a little bit tricky, or with the chronic patients, I ask them, so let's say I evaluate Mr. X, Mr. X, so I would ask him, okay, Mr. X, how does a happy Mr. X life look? So how does this happy life, how should it be a happy life? And sometimes people are really start thinking, sometimes they just say, oh, I'm happy, I just have to get rid of this pain. But sometimes they say, okay, I should be able to do this and this and this, or maybe my mother-in-law has to leave or whatever. So, but that is a very important question. How should a happy life look? So, and that's very helpful, especially for chronic patients.
And you have a good idea of all the other surroundings around the patient and everything that impacts on their health and well-being, right?
Sure, yeah, yeah.
That's a very smart question. And my final question, what personal qualities and abilities do you think are important to become a successful physical therapist?
Yeah, that is actually, that's a funny question, because what is a successful physical therapist? So I think it's about the definition. What is successful? Is it about earning money? Is it about having great results? Then my next question is, how do you know about these results? Do you measure outcomes regularly? Is it about having great feedback from patients? Is it about having a fantastic reputation in the world, in the PT world, or maybe in the small PT world of your city or whatever? So what is a successful PT? So
it's
how
very subjective.
Yeah, I think first of all, you have to think about, what do I want? And if you want to be rich and get rich with physical therapy, then I have no idea what to tell you.
It's going to be hard.
No, it's not. I think it's possible. There are a lot of examples, but I'm not interested in getting rich with physical therapy. If it works, fine. And I think you had other people on the podcast. They know a lot more about than me. And all the other things. If you think, I'm mainly interested in having good results with patients, then you have to find out, how can I evaluate my results? How can I measure what I do? How can I somehow get an idea? Is it me who makes the difference, or other circumstances? So I think the most important thing in getting a successful therapist is to define for yourself, what does success mean? And then look for the appropriate tools for this. Yeah. So sorry, I don't have a good answer on this question.
No, it is a good answer. I think nobody questioned, I don't remember, maybe someone did, like, what is the definition of success? And I think, it depends, and varies, I think, to a lot of different PTs. But I think I probably would say, I think it's you being able to impact the patient's life and change their life and help them. And so I think, just probably my opinion is improving your abilities, your skills, so you are able to help more and more people. And and
then if you end up with this definition of success, then you can see, so okay, what are the skills I need to have? So is it better technical skills? Is it better clinical reasoning? Is it better communication? Is it just you make the patient laugh once in a while, which is very helpful? I just read an article today about a psychiatrist who's an expert, a worldwide renowned expert for laughing in therapy. So what does humor do with patients? So, and it's incredibly important. So maybe you can be a fantastic physical therapist just because you are such a nice, happy, empathetic person, which is not bad. It's not bad to be a nice person and have good results with that. Maybe it's better than manipulate a neck and have good results. So maybe it's better to have a good humor and have good results.
Yeah, and I think helping our patient, all the rest is just consequence. Everything comes after. The patient being happy and you feeling the satisfaction of being able to help someone, and then you having your financial return. And I think all of the rest is just consequence of doing a good job. So
so it works for me. So I have a lot of fun with my patients, and I have 5 kids, and I'm still not bankrupt with all this stuff. So it seems to work somehow.
So, wow, 5 kids. It's a lot of kids.
I'm not yeah, thank you. But maybe I'm not a blueprint for every other, but maybe for some.
Yeah.
So I think it's individual. What is success for you, and what are your personal skills, and what is your potential? So, but yeah, it's good.
Yeah. Awesome. Wonderful. I really love our discussion and conversation. I think a lot of new points we are bringing to the table so people can really stop to think about it. I think that's the goal.
Thank you.
And I really appreciate you taking the time, Georg. And if people want to learn more about you or contact you, is there a way that they can do so?
Yeah, they can just flip me an email on Georg, so it's George without an E, and then at McKenzie.de, or they can just Google my name, and they will find my website of the clinic or the McKenzie Institute Germany. So it's easy to find some contact data, and I'm happy to discuss or answer questions. Fine, will be nice.
Thank you so much. I'm going to make sure to put it on the show notes so people can have access. And thank you again. I really appreciate, and I hope you have a good rest of your day.
Thanks a lot for inviting me. It was an honor, my pleasure, and all the best for you. Stay healthy, and hope we can catch up in the future in person.
Yeah, that would be great. Thank you.
Good. Bye, Mariana. Bye.
Bye.